So I'm really delighted to be introducing Holly Baker-Rand. She's a great friend and excellent clinician who currently is doing her PhD up in Manchester. She's got a really helpful talk for us this afternoon, talking about research in gynae-oncology. So what's out there and what to do. Thanks, Holly.
Yeah, forget everything you just heard from ARCOG, that research doesn't matter. It does. But thank you for staying, those who have. Well done, because you've made it to the end of the longest month in the year as well. So thank you very much. Yes, I am a clinical research fellow and PhD student in Manchester with Emma Crosby, having left my programme at ST6 and diverted via Taunton with Joe Morrison to do some research. But I'm going to tell you what you can do for research in gynae-onc, no matter what stage you are, and most importantly, why bother? So old curriculum they mentioned, but essentially you had to have a research component. So it was the 2 years clinical plus the 12 months of research, but you could get exemption if you'd done the APM, 2 first author papers relevant to the specialty, or you'd done a postgrad research degree. I'm now going to hand over very quickly to Sarah Coleridge, who's going to talk to you about why you should do papers route, because although the curriculum has changed slightly, academic writing is important, and Sarah's here to tell you why.
Thank you. So I'm Sarah, I'm a consultant in Exeter, also diverted via Taunton, and you'll notice that Jo's name is on everything that I've done. She is a great lift as you climb mentor. So I did a 2-year fellowship in Taunton. I really wanted to be the best surgeon that I could be, so I got lots and lots of operating. I did the old style ATSM, I got my COLP accreditation, I did a research master's, and then I also produced these papers. So,
sorry. And this post is available, advertised today. Is that right? Yes.
It is, isn't it? It just came out. So I highly recommend it. There are several people in this room that have done it, and all have mostly gone on to subspec posts so far, haven't we? So a systematic review, Cochrane review, comparing neoadjuvant chemo and upfront surgery. And the headline is there's no difference in progression-free survival or overall survival. A audit on whether the outcomes for women who had PIFU versus clinical follow-up was detrimental to their survival, and the economic evaluation of that. And my biggest one was improving the uptake of cervical screening in pregnant and recently pregnant women, a big quality improvement project. And from this, you have probably heard the old adage, you want to try and get a poster, a presentation, and a publication out of everything that you do, and that is what I attempted to do. And then all of this work led on to being invited to do other things, which have also helped my career. And I think that overall you can do lots of different things because they all interact with one another. And I think that probably the key bit is that doing the quality improvement work, we asked the screening committee, could women have their cervical smears at 6 weeks postnatal? And they said, no, you'll have to go and do an RCT. And Jo Morrison, being the type of person that she is, said, okay, that's fine, we'll go and do an RCT. And so just because you do audit or quality improvement doesn't mean that it can't lead to research in the future. That's it.
So this is the new curriculum. I won't say too much about it because I might say something that will get me in hot water. But essentially, there is just a research SIP now for subspecialty training. There are no mandatory requirements and there's no mandatory evidence. So it's up to you how you interpret it and what you do as a result. But hopefully, I'll show you what you can do and why research is good. So if you are ST1, if you are just going into gynecology and you're thinking you want to do gynae-onc or you want to do fetal medicine or whatever, those of you who are older, encourage your juniors to do these things. Those of you who are younger, do these things. So everyone should do their good clinical practice training. It's free, it's available through NIHR Learn. It's required to do any sort of delivery of research. So if you want to recruit, you'll have to do it, etc. So do it now. You then have to do a refresher every 3 years, but it's there and it's something simple to do. If you're thinking, I just don't know where to start, but how do I recruit to trials? You know, what do I do after I've done my GCP training? Well, if you contact your local research and development or research and innovation, team, they have a portfolio of studies that they're recruiting to. And I think sometimes when you are a trainee, you're not so aware of this, maybe, and it depends on the centre you're in. Certainly, I wasn't in a centre that was linked to an academic institution. So when research went on, there were sort of research nurses who might sort of scurry into labour ward and do things, but it never was that visible. So whether it's an obstetric study you're recruiting to or whether it's a gynae study, see your local department, because they'll be able to see you and maybe coach you and help you. And you'll need them if you want to do a study yourself. Join a research collaborative. So this was pitched as Argo. Argo are the Audit and Research in Gynae Onc. Together, we have PhDs, masters, APMs, publications, etc. as a committee. So we are well placed to help people if they want to do research or they want to get research out there. There are about 150 members. If you want to join, email surgicalgynaeoncresearch@gmail.com, and we can also help you to deliver research within other places. Find a mentor. So my mentor is sitting right down there in terms of research. If it hadn't been for Jo Morrison, I wouldn't be doing my PhD because foolishly she introduced me to Emma Crosby. But Jo has been there as a support where I didn't have a clue about research, and by the time I left Taunton, I had done my APM in clinical research and set up a study and got a small grant for it. And I wouldn't have done that if it weren't for Jo. So you might have excellent PIs where you are, you might be in academic centres where you can come across supervisors, but my sort of plug to you guys as well today is, if you are sitting here and you've got a PhD, you've got an MD, you've got experience in clinical research, please email us and say, I'll be a mentor to somebody who doesn't. And if you are somebody who wants a mentor, then email us. You get the gist. I keep saying the words email us on that address there. And we'll try and hook people up so that they can do some research and have somebody guiding them, because I think that's hugely important. Just write. You can write review articles, case reports, letters. BMJ has some really good information on writing. There are as well to look out for journal fellowships. So TOG has one that comes up for trainee editors. The IJGC has one that comes up, and they're essentially sort of training programs in being an editor for a journal, and they're really, really good. So look out for those. There's the Associate PI scheme, which I don't know if any of you have done. It's really good. It's sort of it's a 6-month, it's in-work training. It's done through NIHR, and you work with a local PI, and the essence of it is that you gain the experience to be able to, in future years, become a PI yourself in a department. So it goes through various things of you're tied to a study, about study delivery, about presentations that you've given about the study, maybe joining a trial management group, things like that. So that's something that's very worthwhile doing. And now the CIPM in clinical research, which I did when it was with the APM. What I would say to you is, if any of you are sitting here starting off again, you can do this from ST3. So it says 18 to 24 months, and it's to develop a research idea and protocol and do things around research governance. Studies take time. They really take time. So this is something that you could very much start in ST3 and take with you moving towards that ST5 and potentially applying. And I would say it's doable outside of big academic centres. But if you're research naive, it can be daunting. Like, how do you start a research protocol? There's lots of advice available through NIHR. Again, your supervisor for this should be able to guide you and help you, and they won't want to see you fail. So get a good supervisor, do some homework. What Sarah showed there, I took her initial idea that she'd done some work on and developed it, and then handed it over to somebody else who's developed it further into a clinical trial. So you know, these things are fluid, and it's not to say you'll do all of it all the way through, but essentially you have to do a bit of homework and maybe have an idea before you go into it. And apply for grants. It's really good to get in the habit of doing that. And it's really impressive on your CVs and applications if you can say, I applied for a grant. And BGCS have every three rounds in the year for grants. There's Wellbeing of Women, have early career grants, and also grants for people going pre-PhD or MD. So yeah, and then my good colleague Helen Clark was going to talk to you about her PhD, but she has had to disappear, I'm afraid, and catch a train. But I could probably say to you, Helen's career took her from doing a BSc through to getting one of the Wellbeing of Women entry-level scholarships, to then doing her PhD in Manchester. I asked Helen, you know, before she had to leave, what would you say about doing a PhD? Would you change it? And how's it been in terms of your training for Gynae-Onc? And she said she wouldn't change it at all. And the skills that you learn in a PhD are phenomenal, you know, because they are essentially a degree in thinking, is what we always say. And so you develop a huge array of skills which are invaluable. And also it's times like this where you realise you also develop a huge number of connections amongst the community and the academic community, which stay with you for a lifetime. So I'm midway through my PhD. It's very daunting at times, but it's absolutely amazing because it just takes you on a different career pathway for a little bit of time to that clinical training pathway. There are various people I know in the audience who will have done degrees and who will have done papers and who will have done the APM. So if anybody has any questions or comments before we all shoot off, then please share them, your experiences, or if you want to be a mentor, then remember to sign up. But the main thing as well is to say, why bother? You've got groins, you've got the LAC trial, SHAPE, is that LACE, CHORUS. All of these massive trials do not happen without research. You can change practice, you can change policy, and you can make sure that your patients receive the best care, not just by the operation you're doing, but into the future with how you're changing practice. So please sign up, and thank you very much.